morning dear students. Myself Dr. M. Ambika, Assistant Professor from Department of Oral Pathology and Oral Microbiology in Vinayaga Mission Sankaracharya Dental College, here to talk about regressive alterations of teeth. So when you see this picture, you can see that there is a destroyed monument or archaeological site you can see. So when you see this monument, the monument has been destroyed, or due to age changes or natural calamities or due to any man invasions, the monument has been destroyed. So from a very functional state, it has been changed to a less developed state. So this is known as regressive changes. So similarly, in our oral cavity also, when you see this picture, the teeth has been attrited, or you can see it has been worn out. So this is also considered to be a regressive alteration of teeth. It may be due to aging process or due to any trauma to the dental tissue like this. So it may be physiological or pathological. So regressive alteration of teeth mainly occurs due to wearing of teeth. So what is tooth wear? So tooth wear is a general term that is used to describe the surface loss of hard tissue other than dental caries or any developmental disturbances. So the etiology is considered to be multifactorial, especially attrition, abrasion, erosion and ABFRACTION. So identifying this etiology clinically in patients as a single etiological factor is very difficult. Okay. So first we will see about attrition. Attrition is derived from the Latin word attritum. It is a physiological wearing of the teeth structure. It is the only physiological wearing of the teeth structure we can say. Others comes under pathological wearing of teeth structure. Okay. It mainly occurs as a result of tooth to tooth contact which happens during mastication, and mostly occlusal, incisal and proximal surface are being involved. And also we can tell that only a certain extent the tooth wear is considered to be as physiological. That is, when tooth wear is seen more than 50 years of age group, we can say it has a age changes and it can be considered as a physiological attrition. When the same attrition is being seen in 20 to 30 age group of people, it should be considered as pathological wearing of teeth. So what are the causes or predisposing factors for pathological wearing of teeth? It may be bruxism, tobacco chewing, clenching, crowding or cross bites. So due to this habitual reasons, it is said to be more common in men. So clinically you can see the flattening of the occlusal or the incisal plane and the loss of mamelon can be appreciated. Even in radiological you can see the pulp chamber or the canal size has been reduced. When the vertical dimension is being lost due to flattening of the occlusal plane, as a preventive measure, excessive cementum is being deposited in the apical area. So this is known as hypercementosis, and hypercementosis can be noted in cases of attrition also. So now we have seen the clinical features about attrition. It is more common in men, and you can notice flat occlusal plane, loss of mamelon, and in few cases you can notice hypercementosis also. So now we are coming to the types of attrition. So it is mild or advanced attrition. In case of mild attrition, if you notice over here, that is the polished facet of the incisal or occlusal plane can be noticed because of minimal wearing of tooth structure. In cases of advanced attrition, you can notice the enamel is completely worn out and dentin is being exposed. In some cases over here, you can notice the pulp chamber is also being exposed. So sensitivity and pain can also occur in few cases, and there will be complete loss of digitation in the posterior aspect, that is the posterior teeth. So these are the two types of attrition. So when attrition is more severe, it may happen, as I told you before, it can happen mostly in proximal surface also, even in incisal or occlusal surface. So if it occurs in proximal area, what will be the final output? So mesiodistal dimension of the tooth will get decreased. So it lead to drifting of the tooth either buccally, lingually or even mesially or even lingually. So this leads to decrease in the arch length and finally leads to altered occlusion. So because of excessive attrition in the proximal surface, it may lead to altered occlusion. So in case of occlusal wear, you can see flattening of the occlusal plane. In severe cases, you can notice in case of posterior teeth, the cuspal digitation would have lost and lead to reverse cusping. In more severe cases where dentin is wearing off in a faster rate, you can notice scooped out areas in the tooth also. So this may be lead to loss of vertical dimension. So in case of proximal tooth wear, excessive attrition, you may notice altered occlusion. In case of occlusal wear, you can notice loss of vertical dimension. So this is about attrition. So now we will move on to abrasion. Abrasion is derived from the Latin word abrasum, that is to scrape off. So it is a pathological wearing of tooth structure which mainly caused by the mechanical process, especially sliding or rubbing of the foreign objects on the tooth surface. So when I say this, first what it should come into your mind when I say sliding of foreign objects on the tooth surface, right? That is toothbrush. So the etiology more commonly we can say is toothbrush trauma or dental floss injury, occupational hazards or habits. Okay, so because of this habitual causes, abrasion may occur. In case of clinical features, we can notice that is severe damage of the intact enamel and there is excessive wearing of dentin and cementum in the cervical area. And if you notice over here, there is a V-shaped or a wedge-shaped area at the cemento-enamel junction. This is the characteristic cervical lesion of abrasion, and the angle formed by this deep V notch is very small, and the dentin over the lesion is highly polished. For right-handed people, if it is a toothbrush trauma, if the abrasion is due to a toothbrush trauma, if for a right-handed people, the lesion may most commonly occur in the left side of the arch. Left-handed people, it will be most commonly seen in the right side of the arch. So these are the clinical features of abrasion. Next, we will see what are the habits and occupational hazards that are leading to abrasion. So that is pipe smoking, tobacco and betel nut chewing, nail biting habit, bobby pin opening and holding music pin instruments. If you notice in these pictures that apart from the cervical areas also, abrasion may occur in other areas of the teeth due to occupational hazards. These also are considered to be abrasion. Okay. Treatment is for anterior teeth, we can go for tooth colored restoration, and for posterior teeth, metallic restoration can be considered. So next we will see about ABFRACTION. So ABFRACTION, clinically it may resemble abrasion, but the etiology is different from abrasion. I told it may be due to some toothbrush trauma or the mechanical process that causing the foreign object to slide or rub against the surface will lead to abrasion. Whereas in ABFRACTION, it is a stress-induced cervical lesion. If you notice over here, the tooth is malaligned. So when during mastication, abnormal forces may be concentrated on the tooth surface. So it may lead to flexure in the cervical area. So it may lead to microstructural loss of the tooth substances in areas of stress concentrated. As you see over here, it may lead to microstructural loss of the tooth structure and may lead to chipping of the enamel. So this is the etiology behind ABFRACTION. So it is ABFRACTION, the word ABFRACTION is derived from the Latin word ab means away and fractio means breaking off. Okay, so it may also lead to wedge-shaped defect similar to abrasion. You must notice that the etiology is different in case of ABFRACTION. So coming to clinical features, it may be seen in buccal or labial area of the teeth. It may be presented with deep V-shaped notch similar to abrasion, but in most of the time it may be presented as a crescent form of cervical lesion in the subgingival area. It most commonly involves single teeth where excessive occlusal load has been concentrated. Okay, unlike your abrasion, the entire arch in the right side or left side, the entire teeth in the arch will be involved in case of abrasion, and but in case of ABFRACTION, only as one or two teeth in a given arch it may be involved. So this is about ABFRACTION. Next, coming to erosion. So erosion is derived from the Latin word erosum, which means to corrode. It is defined as an irreversible loss of the tooth structure caused by chemical substances that does not involve bacteria. If bacteria is involved, means that is known as dental caries. So here the chemical substances that does not involve bacteria that erodes the tooth surface, that is known as erosion. Okay, so the chemical substance may be of intrinsic acids or extrinsic acids. So the extrinsic acids that are mostly involved in eroding the tooth are carbonated drinks like colas or lemonade, citrus fruits, pineapples, and salad dressings containing vinegar. Alcohol like wine, spirit mixed with acidic soft drinks are the external or extrinsic acids that can cause erosion. In case of intrinsic acids, so that is like gastric acids that are reflexed into the oral cavity will cause erosion of the tooth. In which and all conditions like anorexia nervosa, bulimia, and gastroesophageal reflux disease. In severe cases, as you notice over here, similar to your attrition, scooped out area of the occlusal surface can also be noted in case of erosion. So these are the culprits behind dental erosions like soft drinks, intrinsic factors like bulimia nervosa, which causes erosion of the teeth, and most commonly erosion will involve the lingual surface of the tooth structure. Okay, apart from this, coke swishing, lemon sucking, aspirin intake, and wine tasters, you can notice broad concavities on the smooth surface area of the tooth. So clinical features, as I told you, as you noticed in the previous pictures, broad concavities with smooth surface of enamel can be noticed, and there is cupping or reverse cusping of the occlusal can be noted. Due to severe erosion, thinning of the enamel can be seen. So that can be noticed as increased incisal translucency, and in few cases where amalgam restoration is being seen due to erosion, the restoration will appear like a raised, okay, so raised amalgam restorations can be noticed. Hypersensitivity can be seen in most of the patients, and in deciduous teeth there can be early pulp exposure. So these are the clinical features of erosion. So now we have seen about what is attrition, abrasion, abfraction, and erosion. These are the regressive alterations of the teeth. Now we are going to see about resorption of teeth. So resorption means removal of tooth structure by means of osteoclast, cementoclast, and odontoclast. So it can be classified as external resorption and internal resorption. So external resorption can be caused by periapical inflammation or tumors or cyst or reimplantation of teeth. Because of all these things, resorption of teeth occur. And internal resorption, the etiology is unknown, hence idiopathic resorption. So in case of external resorption, it is again categorized as physiological and pathological. Physiological, like as age increases, what are the types of resorptions can be noted? The most commonly is your permanent teeth eruption. So as the teeth erupts, the deciduous teeth naturally undergoes resorption and leaves way for the permanent teeth. So as you see here, this is a deciduous teeth which is undergoing resorption, whereas there is no, in this picture there is no underlying permanent teeth to erupt. So it is a submerged teeth, deciduous teeth. So this is just to notice that this is a deciduous teeth which is undergoing resorption. That is a physiological type of resorption. Okay. So next we will see what are the examples for pathological resorption. So in case of unerupted teeth, you can notice here it is hitting the overlying teeth and it causes resorption of the root over here. And in case of chronic inflammation also, you can notice resorption. The inflammatory reactions can stimulate the osteoclastic cells to cause resorption of the bone and also the teeth structure. And in case of cyst and tumors also, you can notice in aggressive tumors or cyst, you can notice resorption of the teeth structure. So now we will see about internal resorption. This is a very important short note. The resorption occurs from the pulpal surface and is usually associated from the carious lesions or restoration. It is also known as chronic perforating hyperplasia of pulp, internal granuloma, odontoclastoma, or pink tooth of Murmury. We will see how these terminologies have come in the upcoming slides. Okay. So etiology, it is said that invasion of the pulp by granulation tissue caused by the any infection in periodontium or the large carious lesion overlying the teeth. So these are the possible etiologies for internal resorption. So When the granulation tissue occupies the pulp chamber, it causes resorption of the dentin, and the vascular pulp tissue fills the areas of resorption, so giving a pink hue to the tooth structure. So this is the first evidence of internal resorption. Radiographically also you can notice a round or ovoid radiolucent area in the central portion of the teeth associated with pulp. Okay. Coming to the histopathological features, variable degree of resorption can be noted on the inner surface of the pulp and exhibiting lacunar variety where lot of odontoclasts will be resting. Hence the name odontoclastoma. Because of the pink hue clinically, because of that it is known as pink tooth of Murmury. Okay. So again coming to the histopathology, we can also notice chronic inflammatory reaction in the pulpal tissue. So what is internal resorption? It is also known as the chronic perforating hyperplasia of pulp, internal granuloma, odontoclastoma, pink tooth of Murmury. So here the resorption is occurring from within the tooth, especially from the pulpal surface. The etiology may be any infections from the periodontium or from the overlying large carious lesion. Okay. So next we will move on to hypercementosis. It is also known as cemental hyperplasia. We know that hypercementosis means excessive deposition of cementum. Okay. If the cementum deposition is seen in a functional teeth and improving the functional activity of that teeth, it is known as cemental hypertrophy. If the overgrowth occurs in a non-functional teeth, if you see here, if there is a tooth is missing, the antagonist teeth will be having no opposition teeth, right? So that tooth is considered to be a non-functional tooth. So as a preventive measure of supraeruption, cementum may be deposited. Okay. So the cementum deposition in a non-functional tooth is termed as cemental hyperplasia. So now we are going to see about hypercementosis, that is cemental hyperplasia. Okay. So coming to the etiology, what are the reasons behind cemental hyperplasia? That is loss of any antagonist or due to any inflammation of the root, trauma or any systemic conditions like osteitis deformans or Paget's disease of bone, others like hyperpituitarism, calcinosis, vitamin A deficiency, rheumatic fever. These are the possible etiology for hypercementosis. So there are two types of hypercementosis, that is localized and generalized. So in localized, only single teeth is being involved. It may be due to any loss of antagonist or due to any infections or inflammations. In case of generalized, the entire dentition may be involved in case of generalized hypercementosis, like it may be due to aging factor or due to any conditions like systemic conditions like Paget's disease of bone. Okay. So how clinically it will present? It is predominantly seen in adults and permanent teeth are more commonly involved when compared to the deciduous dentition, and it most commonly involve posterior or multi-rooted teeth when compared to the anterior teeth, and no sensitivity or pain will be experienced by the patient, and sometimes it can cause fusion of the roots which cause difficulty in extraction, and roots are larger in diameter when compared to the normal and present rounded apices. Okay. So radiographically what we will see is over here, see the thickening or blunting of the apical area, and here you can notice that there is excessive deposition of the cementum is being noticed, and there is lamina dura will continue like a normal teeth, and the apex appears more or less bulbous. Okay, and there will be irregular accumulation of cementum in areas of bone where the resorption has been taken place. So these are the radiological features of hypercementosis. So coming to the histopathology, as I told you that due to some infection or inflammation where resorption of bone has occurred, the cementum will fill in such areas. So this is an example of localized hypercementosis, that is excessive cementum has been deposited in areas of resorption. Whereas over here you can see generalized hypercementosis, that is cementum is deposited in all the teeth. So you can see excessive cementum deposition. Okay, this is about hypercementosis. So we have seen about resorption, that is external resorption and internal resorption, and that external is physiological and pathological resorption, and in case of internal resorption, that resorption is occurring from within the teeth. And now we have seen about hypercementosis. There are two types, that is it may occur in functional teeth it is known as cemental hypertrophy. If it occurs in non-functional teeth, it is known as cemental hyperplasia. Okay, because of the excessive deposition, the root may appear bulbous, and it's of two types, that is localized and generalized hypercementosis. Thank you for watching my class.